Let's go ahead and get started. Thank you everyone again for joining us today. It is a gloomy day where I am, but I am very excited to be here and hoping that this presentation is a little ray of sunshine in all of our days. My name is Talia Parker. I'm the manager of program operations here at NCSD, and I'm very excited to be joined by Jenn and Barbara today for this fantastic presentation on taking a comprehensive sexual history, why it matters, and what is needed. So I'm going to introduce our two speakers today, and then I'm just going to throw the floor over to them. Just a little bit of housekeeping. As you can all see, everyone is on mute. We'll ask that folks stay on mute for the duration of the presentation. There will be time for Q&A at the end, so feel free to put your questions in the chat throughout the presentation and we'll get to them at the end. And you'll also have an opportunity to unmute and ask your question at the end if you would prefer to ask that way. The session today is being recorded and will be shared after the fact if you want to refer back to it. And I think those are my main notes. So I'm going to go ahead and start introducing our presenters. So Jenn Rogers is an experienced director of family planning, women's health, sexual health, and maternal and child health initiatives. In her role as reproductive and sexual health director at Alterum, she co-directs the National Coalition for Sexual Health, where she creates and promotes high-quality, person-centric sexual health information and health services. Barbara Wilgus is the program administrator for the STD HIV Prevention Training Center at Johns Hopkins since April 2016 and has been a member of senior staff in the Division of Infectious Diseases at Johns Hopkins University School of Medicine since 1997. She is a certified women's health nurse practitioner who specializes in reproductive health, STIs, and HIV. She received her Master's of Science in Nursing from Vanderbilt University in 1995. During her time at Johns Hopkins, she has provided STD treatment and HIV medical management for patients at Baltimore City Health Department and at Johns Hopkins, and has also been research clinician for studies including HPV treatment vaccine trials and vaginal microbiome cohorts. She provided HIV primary care for women at the Johns Hopkins Bartlett Specialty Practice from 2000 to 2020 and currently sees patients for STI care and PrEP at the Baltimore City Health Department Sexual Health and Wellness Clinic. So thank you both, Jenn and Barbara, for joining us, and I will pass it over to you.
Wonderful. Thank you so much, Talia. And thank you all for attending this webinar. As I see it right now, about 182 of you have joined, which is just so thrilling to see so much interest and engagement. If you want, I've seen a couple of people chat in, just hello, if you want to chat in your name and where you're from, and that would be wonderful so we can get a sense of who's in this room, since we can't do, I love doing in-person introductions, but with this kind of group, it's just going to be too much, but hello. I'm really thrilled also to be joined by Barbara. As you heard from her bio, we're just so thrilled to be, I'm so thrilled to be talking and working and collaborating on this presentation with her. And as Talia noted, I'm the director of sexual and reproductive at Alterum. And Alterum is a nonprofit research and consulting organization. And within that, I'm really lucky to also co-direct the National Coalition for Sexual Health. So with that, the next slide, Talia. Great. I'm going to first just give you a little bit of an overview of the coalition. The coalition is funded by CDC's Division of STD Prevention, and it's made up of over now 200 members, and that includes healthcare providers, sex educators, provider organizations, advocacy groups. We're really proud to have both NCSD and the STD HIV Prevention Training Centers as part of our roster. And I'll talk to you a little bit about this in a moment, but we'd love to have all of you join us as well. The goal of the coalition is to make sexual health a common part of our national discourse. And we also really work hard to promote high quality, evidence-based sexual health information and services. And specifically, I think most importantly for this group, our healthcare action group. We have two action groups, one around communications, another one around healthcare. We really are trying to normalize those patient and provider conversations around sexual health to reduce stigma, to reduce barriers, to increase the delivery of preventive services. And then we develop tools for all of you. And so how can we increase the use of our tools to make sure that we're having comprehensive conversations and inclusive conversations about sexual health and well-being. And as I said, as you're participating in this event, if you have any interest in our work or want to find out more, please visit our website, which is nationalcoalitionforsexualhealth.org. Membership is free, and all of our materials for providers and the public are all free. And I really I encourage you to go check that out. Before I go on, I'm going to turn it over to Barbara. She's going to introduce herself and tell you a little bit about the STD HIV Prevention Training Centers. Barbara?
Yeah, so well, you heard a lot about me in the intro, and that's kind of my clinical experience. Next slide. I do want to tell you a little bit about the work that I do as a trainer. So I'm the program administrator for the STD HIV Prevention Training Center at Johns Hopkins, but we're actually one of 8 regional training centers and 2 national centers that make up the NNPTC, which is the national network of STD clinical prevention training centers. And you can see the map here, wherever you're hailing from, because everybody's coming from a whole lot of different places I'm seeing in the chat. So find your place on the map, and that is your PTC. And so what we are tasked with is assisting healthcare providers in training and technical assistance in the management of STIs and also prevention of HIV. For further training, you can go to nnptc.org. We also have a national coordinating center, and then also at the University of Washington is housed the National STD Curriculum. So there's also a consultation service. And so those are all kind of things that you can find out further about at NNPTC's main website. And you can also follow us on Twitter, I can see down there too. So any tweeters out there, come find us. Okay, so handing it back over for the time being.
Yeah, thank you. Next slide, Talia. So this is our roadmap for today. First, we're going to briefly talk about sort of the major elements of a sexual history. But we hope to spend most of our time talking through, what does it mean to take a comprehensive sexual history? In other words, what are the questions might we ask? What tools can we use? And we're also going to go through some practical scenarios and share stories, right? Because we learn from sharing stories, from lessons learned, and Barbara has a lot of those. So we're going to talk through those as well. As Tanya said in the beginning, please feel free to type in your questions and comments throughout. I know it might be hard to sort of follow, but it would be great, especially if you have a question in the moment, put it down. And then we'll try to get to those at the end. And also we'll be sure to leave some room at the end to take your questions. But again, feel free to do that throughout the presentation. Talia, next slide. Great. So this slide probably is not new to any of you. The STI rates in the United States have really reached historically high levels. Nearly 26 million new cases of STIs were reported in 2018. Which means now that 1 in 5 people in the US have an STI costing nearly $16 billion in medical costs. And again, as many of you also know, many STIs are asymptomatic in nature, and which means a lot of these untreated STIs may have severe health consequences. I just started examining the new CDC data, and if you haven't seen it, some of it is really, really striking. And I wanted to share with you 2 maps that really stood out to me. So the first one, if we go to the next slide, is about chlamydia. And in 2011, as you'll see from the state map, 13 states and DC, as well as 2 US territories, had a reported chlamydia rate greater than equal to 393 cases per 100,000. And so that's the darkest sort of colors on the map on the left-hand side there. And then you jump to sort of on the right-hand side in 2020, and this increased to 21 states. So from 13 to 21 states and DC. Again, just the colors on the map sort of took my breath away when I first saw this data coming out from the CDC. And if we go to the next slide, similarly, this is for gonorrhea. I thought this was even more striking, the maps. I see Barbara shaking her head. In 2011, right, it was 8 states in DC had a reported rate of gonorrhea of greater than or equal to 141 cases per 100,000. And then in 2020, it was 38 states in DC. And it just, again, the color contrast there is really what's so striking to me. Again, I know you all know this, but sometimes the visuals can sort of tell the story. Picture's worth 1,000 words in terms of how we're doing with STIs in this country. So next slide, please. So this is why we're together today, is really just to talk more about, why is this so important? Why is the sexual history so important? What does it include and why do we do it? And we know that sexual health is so linked to our overall health and well-being. I think for so long, sexual health was seen as a sort of a side issue or siloed. And we're really knowing more and more that this cannot be siloed, that this is really a part and parcel of our overall health. And it's really important that not only sexual histories are collected, but that they're comprehensive, right? And that they elicit the most relevant information to really identify the appropriate clinical course of action. So when we ask people about their sexual history, when we get a full sexual history, we can increase, STI testing and sexual health services, which we hope will improve patient care and health outcomes. Unfortunately, we also know that providers aren't taking these histories. They're not taking comprehensive sexual histories. And I want to dive into why is that so? Because we talk about this. Why aren't people doing it? What's going on? And let's take a moment to just explore that a little bit. Yeah, thank you. Next slide. Talia, that was great. So we did some look at a meta-analysis, and researchers at the CDC, including one of my project officers at the coalition, undertook a study, and they explored what are the gaps between what's been recommended by CDC in terms of taking a sexual history and what's actually happening in clinical practice. And so they look to see, what patient and then provider and then setting characteristics may influence the likelihood of obtaining those comprehensive sexual histories. And they also examined the patient outcomes that are linked to sexual history taking, so we can get a really clear picture of what's going on. And in the published studies, they found that there were many missed opportunities, even when patients were coming in specifically for an STI-related issues. So among providers, self-report was actually pretty high, right? When you ask providers, are you doing a comprehensive sexual history? 71 or almost 72% say, yeah, I'm doing this. But when they looked at the chart reviews, sexual history was actually much lower, or it was not comprehensive, or just they weren't doing them at all. And we know from other research that patients receiving sexual history during sort of the well exam or a routine visit or an annual visit, if you will, really ranged from only 21 to 30%. And then even those who were coming in specifically for an STI or a gynecological issue, the range of obtaining a sexual history really varied, everything from 8% to 82%. Next slide, please. So they also looked at the patient factors, and they found that patient demographics really seem to influence the likelihood of a sexual history being obtained. So for example, older adolescents, female patients, Black patients, patients with public insurance were actually more likely to receive a sexual history than their counterparts. They also found that as the age of patients increased, so the older that the patients got, the likelihood of receiving a sexual history decreased. And for those folks that where English is their second language, they had real low rates of sexual history taking by providers. As we can imagine, language barriers, perhaps cultural barriers. Next slide, please. They also looked at provider factors. And so they looked at provider demographics, sort of what setting are they all in, the type of physician, and see what might influence whether a sexual history was taken. And they found that primary care providers were significantly more likely to obtain a sexual history than, for instance, emergency room or ED providers or hospitalists. And not surprisingly, and this is good news for all of you, STI clinics obtained sexual histories and asked more comprehensive sexual health questions than any other sort of provider type. So more than primary care physicians, emergency departments, family medicine, so on and so forth. And they also found that demographically, female clinicians were more likely to take a sexual history as compared to male. And I thought this was really interesting that when provider and patient age and sex were concordant, so when both the patient and the provider were female or both male or both older, for instance, providers were again more likely to take a sexual history. So studies suggest, and this is sort of that last bullet on this slide, that providers really may make assumptions about sexual risk, about risk for STI acquisition based on sex, age, race, gender identity, really leading to missed opportunities for care. Next slide, please. So this is where we want to be interactive. And if you would be willing to just chat in some of the reasons why you think healthcare providers don't take a sexual history. You know, in your experience, maybe you're a provider yourself and you're just like, this is why I can't take one or take a full one or take a comprehensive one. I'm seeing a lot, I'm going to go to the chat. I'm seeing a lot of time, discomfort.
Yeah, time and discomfort seem like the kind of main two.
Yeah. Uncomfortability. Some patients are unwilling to share. Time and comfort level. Exactly. Only having 20 minutes. Not wanting to say the wrong thing, right? Not wanting to offend. Especially if you don't have training in this. I think there's some providers that are like, I don't even know how to start this. Too many patients, time consuming. We have 15 minutes, 20 minutes. We just can't do it all, right? This is great. You guys can give this talk. I'll tell you if you want to give the next slide. I'll just tell you what the research says. And the research says that the number one barrier that providers say that they don't obtain a sexual history is lack of time. So lack of time is the chief impediment. Other studies have found, similarly, as you guys all chatted in, that many healthcare providers express discomfort with history taking and with some with general exams. As well as, if you start talking about this, that there could be more conversation around trauma or violence and not knowing how to respond or not having resources to respond or feeling discomfort around that. I think a couple people also chatted in language and cultural barriers, right? Cultural barriers, excuse me. They can play a factor in delivering sexual histories. And I think there's also some patient discomfort around the concerns of our LGBTQ patients. What if they have various concerns? What if I do something that offends? I want to make sure that I'm doing everything right. And so I think there's hesitancy to ask some of these questions. I want to acknowledge that, we know from the research also that there's little formal curricula for healthcare providers. I think that's both for nurses and physicians in sexual health. One recent study just found that 44%, so 44% of US medical schools have no formal education in sexual health. And so if you're not getting the education, it's really hard to then really integrate these kind of conversations in your practice. I also want to acknowledge a couple people wrote in patients, right? Patient reluctance. And I think that's right. I think there's some issues of confidentiality. There was a study done, the CDC analyzed data from the National Survey of Family Growth from 2013 to 2015. And they found that almost a quarter of 15 to 17-year-olds would not seek sexual and reproductive health care because of concerns that maybe their patients would find out. And we know that even with ACA, the wonderful thing is that so many more young adults have gotten insurance, but that has also meant that EOBs can be inadvertently sent home and patient confidentiality can potentially be at risk. And then lastly here, as I mentioned on the last slide, but it bears repeating, I think providers can make assumptions about patient needs based upon all the things, right? And that can really result in possible missed opportunities. So next slide. Okay. So you're not alone. We're not alone. We the coalition has been working really hard to think about, like how can we really help create practical tools for providers. And as part of that, we created these clear and really concise pocket cards. So this card is actually bigger on the slide than it is in person. It's really meant to be a pocket card. And because time is such a barrier for providers, we really tried to streamline these cards. So on the front of this card, as you can see here, we ask specific questions that we believe are the sort of the most essential to influence provider behavior and have the greatest effect on clinical decision making. So if you're going to ask one question, maybe you just start off with, have you been sexually active, or have you been sexually active in the last year? And that can get the conversation rolling. So we really think, also asking about the types of sex and with whom they have sex, what body parts are going into what body parts, really can also be a jumping off for providers to get a clear sense of patient sexual behavior. And then again, that can lead to more questions. I saw someone chatting, can we get these provider cards? Yes. We have a ton of them at the coalition. They're also online, free and downloadable, and you can use them, print them off as much as you are able. And if you're interested in us getting physical cards, you can contact me. I can make sure you get my email address. If we go to the next slide, I just want to show you the back of the card. So that's the front of the card. In the back of the card, what we did here was we highlighted the recommended preventive services. So everything from STI and contraceptive counseling to PrEP. And this is updated regularly based upon the recommended services from CDC and USPSTF. And we also have a line in here for trans individuals as well, with all the caveats, as you can tell, based upon risk. And then on the next slide, I just want to also show you, we created one for adolescents as well. And this one is specifically for those folks that are 13 to 17 years old. This is the back of the card, and the front of the card has really tips specifically for talking to adolescents and some really good resources to point folks in that we think are really useful. So, all right, next slide. So again, those were the essential sexual health questions. Those are jumping off point. We also think it's really important when you're doing a comprehensive sexual history to talk about the 6 Ps. So you may have heard of the 5 Ps approach. That's CDC's 5 Ps approach to sexual history. And those are, as they are listed here, partners, practices, past history of STIs, protection, and pregnancy. And then the coalition over the past year and a half developed this new sort of 6P, and then keeping with the alliteration, right, this plus category, because we thought there's some real elements that were missing in those sort of 5 Ps. And that includes pleasure, problems, so asking about sexual pleasure, asking about sexual problems, and asking about pride, which is really about support for one's gender identity and sexual orientation. I'm sure we could do a whole session where we could brainstorm other Ps, and it would be really fun, and I think we should do that. Because we also think, from an instance, permission, just asking permission to ask these questions is a good P. And there's other Ps we could brainstorm. But we think these sort of 6 are sort of the key Ps, and we're going to go through those in a little bit more detail, but also make it fun with Barbara with telling some stories about them as well. But before we jump into the stories, I just want to, so next slide, Talia. The next slide, we developed, so to promote the 6P tool, we developed this whole new tool, and to also sort of tell the stories from various providers' point of view about why, we wanted to sort of tell the story about why this matters. We didn't want it to be a training video per se, but we wanted to say, why does taking a comprehensive sexual history matter? What are the 6 Ps? What do we want to cover of them? And then some storytelling. We created this video series, and there's 4 videos. They're each only 2 to 3 minutes each. So I really encourage you to go watch them. Again, they're on our website. This video that we're about to play is just the trailer. It's just a 1-minute trailer that sort of sets you up for the videos, but you can give a sense of what they're like and what we cover. And we're gonna play it now, and I hope you enjoy.
I'm willing to learn. I learn every day.
Sex is complicated.
Why do you have sex? Because it feels good.
When I ask my patients about sexual problems, usually they then ask me questions. What do I mean about sexual problems?
They're often so relieved that you asked.
I had an 85-year-old patient. She said, Dr. Jerome, I sometimes have some sexual urges. She went home with a vibrator and she was quite happy.
It's gonna feel awkward initially, but I think the more you practice, the more you incorporate that into your daily practice, and that's how habits develop.
It's critically important, especially in the healthcare system, that we really create an environment that's inclusive for people in our community who are LGBTQ.
My best advice is go at it with a genuine curiosity and wanting to, really give them the best care.
Wonderful. Okay, I'm going to now turn it over to Barbara. She's going to set up the next part of our event here, and I'll be talking to you more in a minute. Barbara?
Yeah, so.
Welcome to today's webinar. My name is Jose Francisco, project manager at the IAS USA.
I have no idea what's happening. Oh, you know what? YouTube's still playing.
Sexual history.
Oops, sorry.
I'd like to welcome today's
Let me stop that. All right, sorry about that, Barbara.
No worries. I was like, what's happening? So what we're gonna do now is just kind of go, oh, you can go to the next slide, yeah. Is go through each of these P's and then have, some suggestive talking points. It's hard to get, in your short amount of time, it is hard to get every single thing, but this is kind of letting you know what kind of the concept is behind each topic. And then I have some just clinical pearls or things from along the way. So next slide.
I'm not going to read these to you. Thanks, Barbara. I'm going to just give you a sense of the kind of questions that are included under each P. And I just want to say, first off, that this is not a script necessarily. What we did here is we brainstormed questions that you might want to ask under each of these. And again, depending on the responses back there, it might go in a whole other direction, or you might want to ask something about something else. So again, or as new information comes, you might want to ask different questions. This is really just to give you a sense of, here are some of the kinds of questions you may want to ask under each of these quote unquote Ps. And I saw that someone asked, said something about open questions, like open-ended questions. I couldn't agree more. Sometimes the best question is saying, what do you want to talk about? Or what brought you here today? Or I want to hear more, or tell me about, right? So yes, some of these feel like more closed-ended questions if you get on that path, but I do really want to emphasize that open-ended questions really are the key, and listening and using their language first. So with that, let's explore the first P, which is partners. Again, we worked with, the coalition worked with a group of about 20 healthcare providers as part of our healthcare action group. And we developed this expanded list. And so this list includes asking questions that try to emphasize relationships and partners. So meaning that, we don't assume a person just has one sexual partner, and in fact, may have many. And so we always use sort of the partners language. And then we also want to try to understand how they think and how they define those relationships, especially when it comes to sexual behavior.
And my pearls here are just to kind of keep in mind when you're asking about partners, you do want to know about the gender identity of a person's partners. You're kind of wanting to know like what parts are going into what parts, which kind of goes into the next one. But a lot of medical records kind of if they have anything at all about a sexual history, they kind of keep it in a binary box, which is like, are you having sex with men or women? But that completely excludes any other gender identity. So typically how I will start is kind of like, well, tell me about the people you're having sex with. When you have sex, do you have sex with men, with women, any partners that are trans? Are they trans men? Are they trans women? And kind of like, keep widening the umbrella until it actually is getting at, who the person is having sex with. So that's one thing. And then the other thing is one concept that we all need to be thinking about now. We all need to be thinking about it anyway, but especially now, when you're thinking about partners, is actually where the person is having sex. Like, where in the world is the person having sex? Which gets at kind of knowing the morbidity of the area that a person is sexually active in. So, like if I'm a single sexually active person in Baltimore, Maryland, which is where I am. So just right out the gate, my risk of an STI is higher just by that one fact than if I live somewhere else where there's, if there are any states with the little yellow morbidity left. I'm not sure where they are anymore, but if there are lower morbidity places, you might not have to offer that person as many screening tests as depending on the morbidity of the area. And then also our lovely emerging sexually transmitted infections. So how many people, you can raise your hand or not, but how many people heard about monkeypox in the past week or two? So, like if you have a patient that you're seeing that's coming in with lesions and, they just were in London having sex, then you might need to raise your radar about kind of emerging potentially sexually transmitted infections, or that they haven't decided if it's sexually transmitted, but there's kind of some association. And so those are other just things that are important under the partner P to keep thinking about. So.
Yeah, Barbara, I love that example. I mean, because it's about close contact, right? And so we can get into whether it's sexually transmitted, but it's the idea that if people are in intimate close contact,
right,
we might not consider it in our field as a sort of sexually transmitted infection, but they can still, because we're in these close proximity, we can really start, this is where we see the spread of these disease. And I think that's really just an important point. Great, next slide. So practices. Practices is the second P. For this P, we really want to understand the behaviors that may lead to, patients to be perhaps at higher risk for an STI. So we need to ask specific questions about sort of what kinds of sex are they having? Is it vaginal, genital, anal, oral? I think it's also crucial to understand whether they give and or receive each type of sex. So, are you in the receiving end or on the giving end, if you will? Have you used drugs or alcohol when having sex? Because that can really impact behavior and prevention. And if they've perhaps exchanged sex for drugs or money or housing, again, I think this helps you get just a better sense of your patient's level of risk and can help you better screen for both HIV and STIs. Barbara, I think you also want to share a pearl of wisdom on this one as well.
I'll share a pearl, and usually in a much smaller, not national format. I have a much saltier way of telling this story. But when you're talking about sex practices, the thing that I want to stress is that really, no matter how uncomfortable you personally might feel, it's so much more helpful if you can talk to your patient in the language that they use to talk about sex. So the story that I have about this that I will completely wash out the way the actual conversation went down. But I had a patient that came in. He'd went somewhere else for, I think, prep care, and they did 3-site testing of everybody because they have that kind of money. And the patient was coming in because he had oropharyngeal gonorrhea, and he was completely angry. Like, this cannot be true. I'm a man, and he's a man who has sex with other men, but he had this whole identity thing going on about, I do not give blowjobs, and, you know, yada, yada, and went on and on and on. And I finally, you know, was like, okay, pause. Do you put your mouth anywhere? And he sat and he thought for a little bit, and he used a term that really meant that he was performing oral anal sex on his partners. And I was like, well, so you had a partner with, you know, rectal anal gonorrhea, and that's where you got exposed. And he was like, oh, like, and then just went on. But, you know, for the past, this story happened in 2019. So for the past like 20 years or so before that, I prided myself on make sure you're saying you're performing oral sex. But my sexual history was, you know, do you perform oral sex on your partner? And if I had asked this patient, so I work at Baltimore City Health Department, we don't have that kind of money to do 3-site testing on everybody. So if I had asked this patient, you know, have you performed oral sex on your partner? And he would have gone into this whole diatribe of, no, I'm a man, I'm a man, I'm a man. And I would have not swabbed his throat because we have to do it based on our sexual history. And I would have missed his oropharyngeal gonorrhea. So that actually changed how I ask about sexual activity. And sometimes, you know, you have to also kind of understand that sometimes a person will be talking about something that they're doing as a practice, and you should never assume, if you're not 100% sure what they're talking about, that you can guess. So a good way to kind of find out is if somebody is talking about a practice and you're not exactly sure, you can say to the person, like, you know, so when you say, you know, you like edge play, what does that mean to you? Like, what does that mean when you're saying that to me? And it can mean something completely different than what you thought it meant. So yeah, and somebody mentions like, be careful using, no, somebody also mentioned tossing the salad, and that wasn't it either. Everybody's making guesses of what the patient said.
They're close though, Barbara. There's a couple of guesses in there. They got it now.
I'm Gen X. Tossing the salad is from my day, and that makes no sense to me. This actually term is real specific, and it gets at exactly what oral anal sex is. That's what I'll say. And so, but anyway, so actually kind of knowing what the language is, and knowing also that it's ever changing and you can't ever assume what a practice is. Always kind of make sure that you're understanding what the person means by what they're saying.
Yeah, thank you for that, Barbara. There's a certain amount of humility in that, just asking folks what exactly they mean and what that means for them specifically. Great. Okay, let's go to the next slide. The next P, or the third P, is past history of STIs. And this one, not surprisingly, tries to, you know, again, elicit information about a patient's history with STIs, where, when, what treatment they have gotten before. The coalition asks specifically about where on their body they've had an STI, again, to really better understand history, risks, and behaviors. So it's, you know, we're not making any assumptions. And we also think it's really crucial to ask about partners and whether they have been treated and when they've been tested for both STIs and HIV. Barbara, I'm going to pass this one on to you because I know that you have a lot of experience with this.
So the main thing that I was going to add is usually, so that this is kind of the yes and no part, but it's kind of the improv if yes then. So I kind of go through the whole list of things, but oftentimes people may not remember what they were treated for, but they remember what medicine they got. So, you know, if I have somebody that tells me, you know, oh, I remember I was seen and I got a shot in my arm and these 4 pills or something, I remember getting a shot and some pills, I can't, you know, check off that they had gonorrhea or chlamydia, but it kind of raises my suspicion. Or if somebody says, I remember getting these 2 shots in my butt and I couldn't walk for 3 days, again, I can't document that they had syphilis, but nobody ever forgets bicellin. So I can kind of raise my suspicion of that. And then the other thing I'll mention here too is sometimes people will have like a history of recurrent symptoms and not an actual diagnosis of anything. So recently, actually, I had a patient that was a cisgender woman, a cis woman who came to see me and had been going to their GYN for like vaginitis, but never having an actual vaginal infection, like just like symptoms of vaginal infection, but then they never had yeast, they never had bacteria, they kept having testing, but nothing was there. And when the person came to see me, they were coming for a different reason. What they were coming for was actually some like genital lesions outside on the clitoral area. And I mentioned to the person, because she said this was just recently had been having all these vaginal infections and going to the GYN and not having anything once they got there. And so I mentioned to the person, first off, I think this is herpes, but also I will be really curious once our results, I treated presumptively for herpes. I didn't wait for the culture to come back, but I said, once the culture comes back, if it's positive, I actually really want to know if like, once you started taking medicine, if your vaginitis symptoms went away too. And it was herpes, and they did. So it was this non-specific symptom that never had any, associated diagnosis. And so that, that is just another thing to kind of keep in mind. Like some things have, like it seemed like a whole lot of other things, but are really this one thing. So if something is missing from the original, that's just something to kind of raise your like flag.
Great, thanks, Barbara. All right, I'm going to cover the next two P's fairly quickly. Yeah. I think probably most of you are very familiar with these, and they cover both protection and then pregnancy. So under protection, this one includes asking what, if any, protection is used and how often they use that protection, and then what with which partners, because some people use some protection with some partners and not with others. So not making any assumptions there. In this one, we also asked about vaccinations, so we can appropriately get folks vaccinated or caught up on vaccines as appropriate. Great. And then pregnancy, the fifth P is pregnancy. And we, again, suggest questions to understand, if your patients want to have children or any more children, what their plan might be to become pregnant or prevent pregnancy until then, and then what steps they might be taking to avoid pregnancy. And I think this also includes the questions about, whether they want to have a longer conversation with you about birth control, about what their options are, and then any potential side effects of those options.
And ask everyone about pregnancy, not just cisgendered women. Ask your male patients, ask your trans male patients, ask your trans female patients, like ask everybody.
Yeah, great point. Okay. This is my favorite one. I know this is a long one, so bear with me. But it's the one that we just created, and this is the plus category that really deals with, again, as I mentioned, pleasure, problems, and pride. And we really wanted to keep it the alliteration, and we tried really hard to do that. And it explores patient satisfaction, functioning, concerns, and then, as I mentioned, support for one's gender identity and sexual orientation. Excuse me, I'm having a little congestion because I'm just getting over COVID. I know this table is small, so we're gonna provide a link in the chat directly to the tool, so you guys can get that. Again, it's free. You can download it, and you can see all these questions. But I'm gonna spend just a couple of minutes highlighting what's included in this. We first sort of offer in the very beginning some tips on how you can begin this conversation, especially if this part is new, about especially around sexual pleasure and satisfaction, just to normalize that. Like, why, so people are like, why are you asking me about this, right? And just saying, and this is familiar language, sometimes we start this off even in the beginning of all of our conversations, it's just part of my routine to ask about sexual health, including sexual functioning and pleasure. As part of your visit, I ask every single person. And then, as someone said even in the chat earlier, to begin with that, those open-ended questions. So, how is your sex life going? What concerns do you have? And then going from there. So we have all these probes, but you might just want to start off there and see what they say, what's coming up for them, and then using that language back, how they use that language, and asking more questions, as Barbara said, based upon what they said, not making any assumptions about what they say about any of that. And then, you know, there's a bunch of probes under here, really, if you need, that asks about sort of their current relationships, whether pleasure whether sex is pleasurable for them, and are they and their partners on the same page about what's pleasurable? You know, do they have those conversations? Is what's pleasurable to you, what's pleasurable for your partners? And then I think opening, you know, asking a couple of questions about, you know, do you talk openly with your partners about your sexual desires and your sexual boundaries? Have you had that conversation? What does that look like? Are you able to talk about that? We also included you'll see under pleasure, sort of a section of questions if a person is not sexually active, and if they'd like to be, right? So including if there's anything holding them back potentially or getting in their way from having sex. For instance, this can really open the door to talk about potential sexual trauma, or maybe porn use, or other potential factors or problems they might be having. In terms of problems, we really focused here on any difficulties they might be having. And we try to specifically name a couple, because I know that sometimes it's hard to sort of say it out loud, but, you know, are you having any pain? Are you having any discomfort during sex? Are you having vaginal dryness, a lack of arousal, a lack of orgasm or erection? This section also includes a question about having either like a low or high level of interest in having sex. And I think more importantly, you know, whether or not there's mismatched sex drives with your partner. And I know this can bring up a lot of issues for people. And I think perhaps this could be even more relevant, this past few years in the pandemic. Some people are just, you know, had enough of being around their partner, and some people, because you have more time and more time with your partner, want to have more, engage in more sexual activity. And then last but certainly not least, in the pride section, we really tried to identify a couple of questions that really just focuses on that support, right? So it's not just asking about those SOGI questions around sexual orientation or gender identity, but really trying to understand what kind of support might you have from your family, from your friends, or not, about your gender identity and sexual orientation. And I think, you know, sometimes asking directly about their experiences with harassment or violence, and even if they don't disclose right away, I think it's just making it known that you're a person that maybe not now, but maybe in the future that they could come to, and that you have resources that can provide support if there's violence or trauma. I also want to mention that at the bottom of this table, it's not on here, but in the tool, we link to some relevant resources if providers need additional support. And then also on the Coalition website, we have a compendium. It's a compendium of all sort of reproductive health resources just for clinicians. And again, they can sort of help you with different resources depending on any of these issues that might come up. And I encourage you to check those out. But I want to turn it over to Barbara once again, because I know she has more words of wisdom around this piece.
Well, so the main thing, so even though providers don't really talk about it, like pleasure is an easy concept, you know, to think of. Hopefully it is, because we're all, you know, sexual beings. We, you know, all have to figure out our own way to have pleasure. So the concept hopefully isn't a foreign one. But sometimes even in counseling people, you know, like I've just treated them for gonorrhea, and my instructions are, you know, that they're not having sex during the time that they're taking medication and until their partner is treated. That could be like a few weeks. And people many times will ask, like, well, can I masturbate? Like, people don't like conceive that masturbation is, I mean, it is sexual activity, but they kind of think of it all together. So I'm like, oh my God, like go home now, like enjoy your, you know, like you're by yourself for this week. So, you know, so what things that can, you know, bring somebody pleasure, but at the same time, especially if they can't be in sexual contact with other people, you know, like how do you kind of make it through your 2-week period of time or whatever? And then the other thing with problems is that just also kind of, you know, be mindful that, you know, other medical problems like untreated hypertension or, you know, diabetes or depression can cause, you know, kind of sexual problems. And so just be mindful that this also could be opening the door to you know, like a need for a more comprehensive workup too. And then I just wanted to give props to NCSH for adding pride, because that's a very wonderful and very important P. So certainly sexual orientation and gender identity, but whatever the person's community is, the BDSM community are very overlooked in the sexual care world, but they're a very tightly knit and very secretive community. But they have a lot of support for each other, and they've kind of figured out ways to kind of do risk reduction, within their community as well. So, so that kind of all falls under pride.
It's a wonderful addition. Thank you, Barbara. Before we open it up to questions, I just wanted to share a fun visual with you. This is a picture actually one of our providers took of a display case that's located prominently in her OB-GYN office. She displays and actually sells vibrators as a way to normalize and discuss the importance of sexual pleasure and functioning, and that this is 100% part of your sexual health and well-being. And so she now sells these vibrators. She told us that she started stocking these and bringing up at the topic, and sort of thought it would just be, I don't know, just again, a conversation starter, but they became so popular that she has sold out now like multiple times. So she jokes that she's not only normalizing these conversations for her patients, but she's bringing in an additional revenue stream. And I thought this was such a great example of a win, really a win for everybody. So I wanted to end on that note. And yeah, that's all from us. I just wanted to, thank Barbara for joining us. And this is our website, the Coalition website. The second link there is if you're interested in becoming a member, we'd love to have you. And I think we'd love to open up to any questions you might have. Please feel free to chat them in right now.
Thank you so much, Jen and Barbara. That was such a wonderful presentation. I learned a lot. Thank you. And so, yeah, like Jen just said, we do have a few minutes for a Q&A. So feel free to add any questions you may have to the chat.
I just put in my email address if people want to jot it down. If you're interested in cards or getting a copy of the slides, or I can also get them to Talia, but this is all for all of you. And all of our stuff is open access and free and accessible. So what's mine is yours. So just be in contact and we'll be certain to share.
Thank you,
I see a raised hand.
I think that might have been from earlier, but Norma, do you have a question? I think it might have been from the monkeypox question earlier. Oh. But thank you, Jen, for offering to send out the slides. I will we'll post the recording and the slides to our website, but I will go ahead and send that out to all participants today as well. Let's see, I see some questions. How should we give support and appropriate care to people who are intersex?
That is a wonderful question. And so I am going to assume, so tell me if I am interpreting what you're saying correctly. By intersex, you mean a person who is neither assigned female nor male at birth. So it could be one of a variety of medical conditions, correct? So am I assuming that correctly? Yes, okay. So, so it's gonna be very specific to the person's medical conditions. Your biologic sex is not the same as your gender identity, is not the same as your sexual orientation. So it's, in some ways, it kind of depends on what the person's actual medical condition is. as far as like what medical care you would need to provide. But then, you know, kind of support wise, in general, I would say more of the kind of support comes along with a lot of the not emotional burden. I'm not thinking of like what the word I want to use is, but like the burden of someone, you know, like walking through their life, being biologically both. And that can have an impact once someone, you know, when someone knows their gender identity, if there is a physical difficulty, you know, so for example, if someone is, you know, has, you know, both male and female genitalia, that can actually, you know, along the way of, you know, becoming sexually active or figuring out parts and things like that, that's when that could be an area where, you know, some of the support might be in talking about like the person's, whatever their gender identity is. Now, how does that work with the body that you have? So it's kind of a hard question to answer because it kind of goes into sort of the art of medicine more than the science, because there's just so much there. But I would say kind of depending on what the person's intersex, you know, kind of biology is, and going from there. My very first job in a private practice OBGYN in Tennessee, I went up against the United States military because they didn't want to let a person in that had testicular feminization, which is, you know, like the most famous example of that is Jamie Lee Curtis, where somebody is assigned female at birth, but actually were, you know, like genetically and some organally male, just with undescended, you know, testes. And so that oftentimes people don't ever find out until they don't have a period. That's because nobody would ever think to like do any kind of organ exam, you know, until somebody actually is at puberty and something isn't happening. So this person wanted to go into the military, and the military was like, "But you're a man." But no, that's not the case. So it was months and months and months. It was one of my proudest things as a 23-year-old was getting her in the military. Now she's blowing things up somewhere. I don't know. But sometimes that is, you know, supporting a person in the life they want to live, which they should be able to live no matter, you know, what. So anyway.
Thank you, Barbara.
And then the last one, I know we're going to wrap up here, Talia, but I just saw a question about this person likes the idea of normalizing sex products. How, you know, can you carry a wider variety, but also what's a good margin to keep patients comfortable? That's a great question. I think you should try it out, and then you come back on the next time and tell us what is the margin of variety that we can provide people to really normalize. I'd love to see it be more and more normalized. So I'm all supportive for that. And I think it's a great idea to mix it up and make these conversations about sexual pleasure really part of the norm.
Absolutely. Well, thank you everyone for joining us today. I'm going to launch a quick poll just to have you all rate how helpful you found today's webinar, just so we can get a sense, but feel free to email myself or Jen or Barbara with any additional comments or feedback if you have it. But I want to lead everyone in thanking Jen and Barbara for joining us today for this lovely presentation. And thank you all again for joining us this afternoon or morning, depending on where you are. And I hope you have a lovely rest of your Tuesday.
Thank you, everybody.